Welcome everyone, and thank you for joining us today. My name is Maria from the National CLEAR team, and I'll be co-hosting today's webinar with my colleague Claire. This session is part of our CLEAR Impact webinar series, which brings together those involved in delivering our transformation projects to share their learning and impact in their work. I'm sure my colleagues will put it in the chat, but just a reminder that this session is being recorded so we can share amongst in our website and across all our networks as well. Today's webinar, as you may know, will discuss how different sites can develop or optimize the same-day emergency care service. SDEC has transformed the way urgent and emergency care is delivered, playing a key role in reducing demand, improving patient flow and enhancing an overall experience of care. We'll also share the learning from CLEAR work in this area, and we'll also hear from NHS England colleagues who will share the latest thinking and the national context around SDEC development. Next slide, please. So today we'll be joined by myself, Claire and James, all from the National CLEAR programme, Dr. Nick Scriven, a consultant in acute medicine and national specialty advisor for acute medicine in northeastern Yorkshire, Dr. Tara Sood, also a consultant in emergency medicine and national specialty advisor for same-day emergency care for NHS England. And finally, but not least, Dr. Aaron Saha, also a consultant in upper GI bariatric and general surgery at Cuddleday and Huddersfield NHS Foundation Trust. So let's just take a look at our agenda for today. Claire will kick off the proceedings by going and giving us an overview of the National CLEAR programme, followed by Nick, who will give us an historical context for SDEC development, and then Tara, who will provide us an overview of the national strategic context. I will then follow and give you an overview of practical steps that you can take to develop an SDEC based on learnings from the national CLEAR programs in this area. And then we'll go into some case studies. James will cover our work where we have supported the integration and implementation of a medical SDEC. Claire will discuss a frailty SDEC project at QEH, and Aaron will discuss the development of a surgical SDEC at Huddersfield. And we'll finish off with our usual Q&A, which will be an opportunity for you to ask questions, both in the chat or verbally. So that's all for me at the moment. I'll now pass on to my colleague Claire. Thank you.
Thanks, Maria. Welcome, everyone. Thanks for taking time out to listen to our webinar today. I'm just going to give a quick overview of the CLEAR programme, just for any colleagues that haven't heard of us before. So just move on to the next slide. The National CLEAR programme was originally developed in partnership with Health Education England, but now sponsored by NHS England, with regions and systems being involved in the commissioning of the programmes. CLEAR stands for the Clinically Led Workforce and Activity Redesign Programme, and what's unique is that it places clinicians at the heart of healthcare decision making and innovation, and we combine clinical insight and data analysis to create innovative new models of care and workforce redesign. The CLEAR National Programme is hosted and delivered in partnership with East Lancs NHS Hospital Trust. Next slide, please. So as you can see, CLEAR has supported the NHS across a number of areas across England, and over 60 projects now have been completed or are underway within the specialities that you can see on the map there. So I won't take a lot of time. We can move on to the next slide for that one. And just a little bit about our approach. We have a methodology which has 4 key stages. We have a qualitative stage which understands demand and lived experience of frontline staff and teams. The quantitative approach then reviews and performs in-depth data analysis from patient-level forums. We then review and understand key challenges and work with frontline teams to co-develop and innovate new models of care and workforce, and then publish recommendations, potential outcomes, including implementation support, which you will hear about later on in the case studies. I'm now going to hand over to Nick, who's just going to give you some more context around SDECs.
Thanks, Claire. Thanks everyone for joining us. I'm Nick. I'm the consultant in acute medicine up in sunny Yorkshire today. So first slide, please. This is historical. You'll spot a very young me in the background, but this is to remind you all that ambulatory care or SDEC, has been going on for many, many years, not just the last few. I've been doing or involved with it for about 24 years up in Yorkshire, where it started with a DVT service and has progressed through what's called ambulatory units and the AAC network. Next slide, please. And then we started getting recognition. The Society of Acute Medicine at Royal College of Physicians of Edinburgh again took a photo of our unit up in Calderdale and produced some guidelines. We have to note the contribution of the great Cliff Mann, who really invigorated this probably about 6 years ago now. Other people interested in it back in prehistory, before COVID, were NHS England, Society for Acute Medicine, RChem and the RCP, who all had fingers in the pie of this. Next slide. In recent times, in the last 2 or 3 years, we've had input from all regions of the United Kingdom, UEC people, RChem, SAM, and all the Royal Colleges. I've yet to see a unit that looks quite as empty as that picture. So next slide. First thing to look at in recent history is this. This is something from a UEC review from NHS England, but it's not wholly English. It's what's called maturity indices, and these are designed so you can benchmark your own services. So just very quickly run through them. So next slide. So these were put out only 2 years ago, and they still hold to a degree now. There are 10 there that you can all see, and they run through the staffing models, senior clinician decision makers available during peak hours, a minimum of 12 hours a day. You should have access to SDECs with minimal exclusion criteria. The thing I think we're very bad at is getting regular audit activity, especially patient experience feedback. See, these maturity indexes said it should be done 4 times a year, as well as doing demand and capacity modelling twice a year to maximise your service. I suspect that's not done very much. SDEC activity back 2 years ago was via the APC. It is being transitioned, or should have transitioned, to ECDS. That is still ongoing work. Handover should be as per usual. 2.18, SDEC should never be bedded. 2.19, SDEC has rapid access equable to ED for diagnostics 7 days a week. Both those things are still up in the air a little bit. And then the bottom one is suggesting that a minimum of a third of your non-elective activities should actually be going through an SDEC environment. Most of these, as you'll see in a bit, will still hold today, but they're a good basis for benchmarking your own services. So next slide. So over the last year and a half, we've had various definitions. This is one of the NHS England ones. It's a very good one. You need to highlight that these are patients who will be treated on the same day of arrival who would, and in big bold letters, otherwise have been admitted to hospital. It is part of a wider UEC system and should be integrated so patients see the right person first time. With Cliff's work in NHS England, these models were adopted nationally in 2019 to try and push them out across the whole of the NHS. Next slide. So this was the buzz phrase, the same day strategy, with several priorities across the SDEC. Staffing is safe, you get access, you're monitored, you've got a good estate, you've got diagnostics, and it is an alternative to admission. And you've got a facility to make change. So they're the big strands that run through the whole thing. Next slide. Recommendations from the same day strategy was that you should minimise the time spent wherever you are prior to SDEC. SDEC activities should be protected, i.e. not bedded. Waiting time should be minimised with things like the news score done within 15 minutes and 60 minutes to see a clinician. Importantly, communication with primary care should be done on the same day as the episode. And no one should stay in an SDEC service longer than 8 hours. Next slide. Lots of metrics you can collect, but these were the ones that were suggested in the same day. It should be a monthly review of activity, number of patients, the length of stay within your service, what your conversion rate is that leading to missed opportunities? What is an ideal conversion rate? Most SDECs seem to be running around 90 to 95% at the moment, some down at 90, some down at 85. In the latest documents, they're suggesting it should be about 80%. Get home on the same day if you're taking the right patients in and using the right processes. Other metrics would be the total time of patient arriving in the hospital, the numbers of where they come from, where you discharge them to, and the number of unplanned representations for people who've been in your SDEC service. Crucial that you're not discharging patients who then get admitted the next day or the day after. Next slide. So what's going on here and now? We're having pressures, complexities, and all sorts that we probably never even imagined 4 years ago. And over the last 6 to 8 months, there have been two main statements. There was one from RChem and SAM, and then from SAM again. So we're on to the next slide. This is a joint statement that we initially put out probably about 3 or 4 years ago and was refreshed last year. It is agreed by both RChem and SAM. There's lots on it to read, but the important bits are that it's a skilled MDT that avoids admission, with diagnostics available within ED timeframes 7 days a week. It's not somewhere that people go just to have a diagnostic test. It's not somewhere to go if you're not going to be admitted. It's not an alternative to an inpatient bed. It's not a place to wait for an inpatient bed. And it's not a zone where people can wait to go home, aka a discharge lounge. And again, it is not bedded. That was fully agreed and was put out. But with the next slide, Society for Acute Medicine were getting a little bit anxious around how SDECs have been used and put out this statement late last year, calling it a need to pause and reset. This was just a SAM statement, but it was approved by the Royal College of Physicians of London. Ambulatory approaches, aka SDEC, is fundamental to our practice, as it manages patients who would otherwise be admitted, blocking up our wards even more. So very rich environment for training, all the MDT, and various statements were made, which are on the next slide. Recommendations. These are important. These are the most recent set of recommendations that are floating around, especially for medical SDEC. So the first one is that patient selection should have an agreed process with clinical leadership from the acute medicine team. So the acute medicine team should give you the guidance about which patients should be going to a medical SDEC. Recommendation 2, appropriate diagnostics should be arranged before transfer if required or when required. But the system should expedite patients moving in an efficient manner. Again, medical SDEC should not be used for patients who are more appropriately managed by other services, including those needing emergency treatment in the ED, UTC, primary care, community care, or other specialities. You should not be penalised for bringing patients back to SDEC, having seen them, because complex patients can be managed in SDEC and they frequently need more than one visit. You should have the appropriate resources, and these need to be frequently assessed and re-evaluated. And again, there should be zero tolerance of bedding. So next slide, which I think is probably the last one from me. So the futures, areas you can look at to optimise your medical SDEC. There are various service specs. There's the NHS England same-day emergency care service spec. For your estates, there's what's called a health building note, which outlines what your facilities should be in your SDEC unit, if you have a unit. There's heap loads of stuff on NHS Futures about staffing and workforce and MDT opportunities. And there are lots of conversations about SOPs and how you do things. So there's a big community out there, lots of SDEC work, get involved. And that was my last slide. Thank you. I think I'm now handing over to Tara for a more coherent national strategy.
Thanks, Nick. I'm Tara Sood. I'm the National Specialty Advisor for Same Day Emergency Care at NHS England. I'm just going to spend the next 5 minutes or so just talking about the national strategy for same day emergency care. But Nick's already spoken a little bit about that and trailered some of the things that I'm going to say. Next slide, please. So as Nick said, same-day emergency care originated a while ago in the last decade with ambulatory emergency care, with a group of enthusiasts who really kick-started this as a concept of how we can manage patients who would require admission to hospital but without the need to be admitted. And it's really evolved considerably with the advent of new ways of being able to investigate and diagnose and treat patients on the same day, as technology and access to diagnostics and different biomarkers have been developed. SDEC has a really important role in modern healthcare, and every site in NHS England, every acute site in the NHS in England now has a same-day emergency care unit. It offers better patient experience and satisfaction. Patients receive treatment in a dedicated space with early access to diagnostics, investigation and treatment within the same time frame that they would do if they were within the emergency department. This allows enhanced patient safety with early access to senior clinical review and avoids unnecessary admissions, as we've already discussed, and contributes to overall operational and hospital efficiency, reducing ED congestion, diverting patients away from our crowded emergency departments, allowing the staff there to care for the patients who require more intensive treatment and management. Supporting improved flow of patients, freeing up inpatient capacity for those patients who need that inpatient bed most, and potentially also supporting reduced length of stay. Same-day emergency care offers a good workforce experience and allows us to develop a sustainable workforce that's resilient. Staff members who work within our same-day emergency care services have a good staff satisfaction survey, and surveys have shown that clinical teams enjoy working within this space and working in the MDT environment. It enables development of staff skills and expertise, and there's that cross-pollination of skills between different clinical teams, allowing people to develop their skills, and particularly upskilling different staff cohorts such as advanced clinical practitioners and physician associates, and strengthens the multidisciplinary teamwork that we have, requiring close collaboration across specialties and care settings, including acute specialties, primary care, and those clinicians who work outside of our traditional hospital four walls within the ambulance service, pre-hospital, and within the virtual ward team within our communities, fostering a more team-based approach. Next slide, please. So our national priorities are aligned with the 25-26 NHS operational planning guidance, emphasising increasing the proportion of patients treated and discharged on the same day using SDEC principles. And the key principles which I think we would like people to take home from this webinar are trying to not bed your SDEC service. Non-bedding your SDEC is a complete own goal and reduces the ability of patients to flow through the acute care system. It takes about 3 days to recover if you bed your SDEC service. And we've got several podcasts on our NHS Futures platform from sites who talk about their journey from bedding to non-bedding their SDEC and how they've achieved that. Every SDEC should be operating 12 hours a day, 7 days a week, as per planning guidance, and all sites should be recording their SDEC activity via the emergency care data set as type 5 activity, and about 50% of sites are currently doing this, so we're about halfway there. Understanding your activity is really important, and Nick talked about the metrics, and those are really important, not only to ensuring that we've got the right patients within our same-day emergency care services, but also that they get a good patient experience. And this will inform further discussions about developing a tariff for same-day emergency care in the future. And widening the scope of opportunity using the SDEC index as a guide to increase the number of patients that we're looking at managing through our same-day emergency care services, enables innovation in this space and widens the scale of the opportunity. Next slide, please. So the current status is that we've got about 80% of patients, or 79% of our medical same-day emergency care services are operating 12 hours a day, 7 days a week. About 64% of our surgical SDEC services are operating 12 hours a day, 7 days a week, and about 54, so about just over half of our frailty SDEC services are operating as per guidance, which is 70 hours per week. So we've got a bit of work to do around our frailty services, pulling that up to where our medical SDEC is, and that is a bit more challenging because it requires usually a more MDT approach. But this just highlights that there is still a little way to go. And obviously, those more frail patients are the patients who would benefit most from an SDEC approach in most circumstances. So it's really important that we have a focus on identifying those patients early within the patient journey, and adopting an SDEC approach towards patient management where possible. Next slide, please. So thinking about how you might improve what you're delivering or develop your SDEC service, there are sort of 10 ideas to think about within your own services to help you on that journey. So profile your demand for your SDEC service and adapt your core operating hours to meet that demand. So do a bit of demand and capacity modelling to make sure that you're not just opening 8 till 8. Sometimes for the first couple of hours we're relatively underutilized within that space, and it is challenging to move your delivery towards the end of the day, but that's where you might have more opportunity to avoid admission. Look at your provision at weekends and out of hours to meet demand. And we've already talked about not bedding your SDEC service, but think about how you develop those local agreements and get your exec to buy into not bedding your SDEC services overnight to maintain flow. Establish team job plans which support early review of all patients by senior decision makers, and make sure that your resources are pointed towards delivering SDEC services both operationally and clinically. Ensure that your services are profiled on your directory of services to allow direct access from your ambulance service so that the right patients can get to the right clinicians and right space in the right time frame. And establish local access criteria for ambulance referral. It's important, as I've said, to ensure all your activity is recorded on ECDS to ensure that we can monitor activity and improve it. And later on, this will inform how patients how this activity is paid for with a tariff. And how you co-locate your SDEC services with specialties is really important. So think about how you have an emergency floor or where your SDEC service is located to ensure that patients can flow in and flow out, and to support that MDT working. Use your self-assessment tools to benchmark and address gaps in your SDEC provision to make sure that you can improve your service and put some quality improvement methodology behind that. Next slide, please. So I'm now going to hand over to Maria to talk about how to set up a same-day emergency care service.
Thank you very much, Tara. Lovely. So I'm going to try to be quick, just because Nick and Tara have already given us a lot of information and a lot of things that we would integrate into our steps, and things that we have taken in consideration during our projects. Just to caveat that this is a very high-level step-by-step guide. This is not the only version of truth, but it's based on our previous work where we have supported different providers to set up their same-day emergency care services, both in medical, frailty, surgical, and gynae areas, to ensure that they hold all the right information, but also aiming for a high impact for their patients. Next slide, please. So if we start with setting up the need, step one, set up the right transformation working group. You want to consider who your stakeholders are from your senior leadership, operations and clinical teams with a multidisciplinary approach. And what we really want is to generate buy-in. You want your friends with you, but you also want your critical voices next to you from the very beginning. So make sure that you have them next to you. Define the purpose and the anticipated impacts for your SDEC. Think of what does good look like for your patients and for your trust and for your staff. Number 3, gather a collection of data-driven information to share with stakeholders, highlighting the need for a new service. So consider a robust process of clinical engagement to understand your enablers. What is it that your team do really well already, but also what challenges do you have there to implement or to make more efficient the service that you already have? But also going back to Tara's point, review your patient activity data, understand who your cohort is and what your potential activity is going to be in your SDEC. When does your cohort attend, lengths of stay in A&E, their clinical presentations, their admission rate, lengths of stay, demographics, amongst most of them. Next slide, please. Once you've done that, you need to build your implementation plan. For that, my suggestion would be that you define rigorous timelines to work against and allocate an owner for each activity. You define your end-to-end patient journey. Think about your patient as soon as they step into their health journey. What is it that they will go through until they reach your SDEC? Or since where do their journey can start and where do you want it to finish until the patients go home? Build your requirement plan and understand the gap. Look at your workforce, the WTs required, the costs, the new ways of working that you would like to implement, the training that is required. Look at your estate, the equipment that you need, technology and data. We were talking just now about TCDS as well. Look at what you have and what is the gap that you need to bridge. Number 4, calculate the potential impact of your new service. What are the benefits? Look at the benefits for your patients, staff, but also for your trust or your service. How many admissions and bed days can be saved if you implement your SDEC successfully? How many ED attendances can be saved? And how much staff time can be saved in ED and assessment areas, but also in admission wards? Determine if you have the capacity to meet all the requirements for 100% of your cohort demand and if you need to scale down. It is okay to start to not aim for the 70 hours per week on the first week. It's okay to start with a smaller portion, lay out all your processes, make sure that you're doing okay before you scale it up, as long as you have that plan to go through. Next slide, please. Lastly, on the implementation plan, define the government and the structure of a new SDEC. So what you need, we just talked about opening times, new roles and new ways of working. Do you need new JDs? Do you need to go through a process of HR with consultancy for the new roles with the team that you already have? You need to look at your new SOP, new inclusion or exclusion criteria, depending on the way how you want to go. Think of the method of the referrals. Do you want a self-assessor model, phone calls to refer the patients in electronic form, etc.? Think of your sources of arrival. We don't want the patient to spend any longer than an hour before they reach your A&E. So make sure that they can be referred the earliest in their journey as possible. So for that, you can think about direct referral sources from the ambulance services, 111, primary care, but also A&E for all the other patients that walk in, and the service level agreement to do so. Do a detailed plan about your staff training, but also an internal external comms plan. If you are opening an SDEC, who is it that you want to know about it before you open it? Who are going to be your partners and who is going to be able to refer in? It's really important. Next slide, please. And then finally, the opening. If you are happy with all the other steps, you're ready to open. Set your expectations, gather everyone that is involved in anticipation for the launch and set a scene for the new roles, the patient journey that you are trying to achieve, the processes that you want to define KPIs that are going to be monitored, and what is the plan for the monitoring of those KPIs, but also allow for a safe space for concerns to be raised from the staff and for problem solving. Number 2, provide targeted support for all staff groups for defined periods to consolidate processes. Don't anticipate that everything is going to work out well on the first few weeks. There is going to be hiccups, and make sure that you have a plan to support those different staff groups at different points throughout every day to make sure that that staff feels heard. Monitor progress and give emphasis to continuous improvement. So we would say monitor data regularly, although we would expect you to monitor data monthly once the service is set up. It's probably wise to do it more often as you start, probably weekly, and then start augmenting the periods of data monitoring. Monitor the feedback from your staff and your patients and do it in a systematic way so that especially the staff, know that that's happening and that you're responsive to it. And maintain regular meetings with your SDEC working group to ensure the support and minor changes happening when they need to. Finally, trust the process, trust the team that you have, and celebrate the success. Take time to celebrate that success with the team when you reach that point. Next slide, please. Lovely, thank you very much. I'll now hand over to James, who is going to present to you the first case study from BHRUT.
Thank you, Maria. Hi everyone, I'm James. I'm a senior clinical consultant in the National Clear programme, and I was the project lead at the King George's site at Barking, Havering and Redbridge Trust, looking at the medical SDEC project. Next slide, please. So I won't go over the project process too much. You can see some of the key details on screen, but Claire and Maria have covered that quite a lot. I'll just give you a little bit of context in terms of where we started. So BHRUT has 2 sites, King George's and Queen's. Our focus was first on King George's. They had a medical SDEC in name, but not quite in practice. So it was functioning partly as a medical SDEC, partly as an overflow short stay medical unit. And the ability to perform a medical SDEC service was quite severely hindered by the fact that there was the short stay unit, and the consultant time and the nursing time was mainly dedicated to those short stay patients. At Queen's Hospital, they had a very small, overwhelmed ambulatory care unit. And so the aim of the project was to look at both sites and establish how we could set up a true medical SDEC on both sites. Next slide, please. So fast forward through 4 months of extremely hard work and really close collaboration with the medical SDEC team at King George's Hospital. So November last year, we relaunched the medical SDEC service, having redesigned it in collaboration with them. The key things that we put in place, amongst many other improvements and recommendations, were patient pathways with direct referrals from primary care, London Ambulance Service, PELC, which is the urgent treatment centre on the front door, and ED. That went alongside the inclusion-exclusion criteria that we put in place. So that really helped give those services clarity into who they were referring into SDEC and how they were referring into SDEC. Alongside that, we implemented a new workforce model, and the key part of that was the empowerment and the consolidation of the nurse coordinator role. Whereas before it had been a consultant-led service, and obviously consultants are on rotation across the medical division, so there was no consistency there. Having the nurse coordinators in place, so there were the 2 people sharing that role, that led to consistency in terms of decision making and real empowerment of the nursing staff who carried that service. Also really important in that service was the transition to digital record. A lot of what they were doing was on paper and on whiteboards. And so through the project, we supported them to move everything to their electronic system. And that in turn helped with their medical note filing as well. And I think throughout the project, throughout the lead up to the relaunch, and then since the relaunch, there's been a real consolidation of process, and that's been under constant review with that key stakeholder group to look at how the processes can be tweaked to benefit the staff and the patients. Next slide, please. There's a nice photo of us on the relaunch day with the medical SDEC staff. Next slide, please. So some of the impacts that we've had to date. So this is now about 5 months worth of work. Patient satisfaction was sat at 90%. In fairness to the medical SDEC staff who were performing a brilliant job before with what they had, that patient satisfaction was more or less the same before. We led a review workshop with the staff a couple of months ago to get their feedback on how they thought the service was going, and the feedback from them was overwhelmingly positive. And if you look at the figures, there was a 42% increase in daily patient activity, so that's taking into account both the short stay patients and the SDEC patients. And if you look at just the SDEC activity, there's been an over 300% increase on that activity from pre-relaunch to now. A 90% increase in follow-up patient activity on top of the overall activity, and a 6.7% decrease in admission rate from SDEC. And as I mentioned before, those direct pathways have been established into SDEC, which has been absolutely key into getting those patients into the right place, and most importantly, avoiding ED where possible. Next slide, please. So this is probably my favourite graphic from the project. So if you look at the left-hand axis, you can see the numbers. So that corresponds to the dotted line. The average patients that we had, and this is a 5-day service at the moment with a view to setting it up as a 7-day service in the near future. So this is just Monday to Friday. You've got on the dotted line the trend that shows the weekly numbers of patients coming through. Bear in mind that pre-November, this was looking at about 40 to 50 patients a week. This has now gone up to 120 when we started on average, and nearing 160 now as we've left the project at the end of March. So almost 30% increase in intake just from November to March. And what's most important there is the orange line. So the orange, blue and green lines correspond to the percentages on the right-hand side. So you can see that the percentage of attendances coming via ED has been cut by more than half, whereas the green line, which is the line of patients coming in directly from either primary care, ambulance service or the front door urgent treatment centre, has significantly increased. The number of follow-ups has maintained fairly steadily throughout. Next slide, please. So looking at the impacts that we've already realised in that short space of time, I've already talked to the first one. We've had over 2,700 patients that have gone through the medical SDEC service since relaunch in November. So those patients have all had that improved service. They're all most of them are avoiding ED now, and a lot of them are avoiding admissions that they otherwise would have had. The SDEC length of stay has been reduced from 13.7 hours last summer to now down to 4.7 hours. And as I mentioned, those ED attendances have been cut by more than half, whereas the direct attendances to SDEC have increased quite significantly. And the admissions to SDEC have been cut significantly as well. Next slide, please. I talked about Queen's Hospital being the second site. So the work that we've done at King George's Hospital and the work that we've set up for Queen's Hospital, we've given them now an options paper and an implementation plan to replicate at the second site. If all SDEC patients that we've identified that are going through ED currently are rerouted to an SDEC, you're looking at an improved patient pathway for over 33,000 patients per year in the one hospital. And you're looking at around 260 staff hours saved across ED, CDU and inpatient wards. That's per day. You're looking at significant reductions in both ED and short stay medical intake cohort size. And you're looking at a potential equivalent to around £15 million per year in savings equated to ED and ED attendances and admission avoidance, and over 7,600 bed days saved per year. I think all of those figures, particularly the bed days saved per year and the reduction in ED cohort size, is something that hopefully will resonate with all trusts as key targets to aim for. And that, I think, is the end of my part, and I'll hand over to Claire now.
Thanks, James. I'm now going to talk about the frailty SDEC that we helped to launch at Queen Elizabeth Hospital in Kings Lane back in 2023. Katie Honey was key to helping us. We worked very closely with Katie Honey, who was a consultant geriatrician, but she's unfortunately unable to make today. So basically, just a bit of context around what we did. Norfolk and Waveney ICS got a high number of frail older patients with complex needs, and they had a high number of frequent ED visits and hospital admissions, as we've seen all over the country. So our project started back in 2023, working with the Trust, and we did workshops, site visits, did clinical engagement and observations, speaking to over 40 staff within the project process. If you just move on to the next slide. I just want to go through really, because we talked about the methodology right at the beginning of the CLEAR programme. I just want to talk a little bit about our methodology for clinical engagement and data, and the key themes that we got from the clinical engagement when we spoke to staff about the frailty pathway was these 6 high-level key themes. So a lot around workforce not meeting patient demand, and that was not just around the hospital workforce, but around the community workforce and social care. Unclear and undefined pathways, and again, patients end up in ED, and staff there are swamped with where to send these patients and the services that are around to support them. Admission avoidance services were not optimised. As we know, there's an increased complexity of frail patients, no clear description for coding for frail patients, and there were communication inefficiencies as well within the whole system. If we move on to the next slide, I just want to show you some slides around the data analysis that we did at QEH. 18% of all ED attendances at the time that we did our data analysis were frail patients. That equated to 36 patients a day. 68 of those attendances attended between 8 and 8. So we knew that there was a cohort that were attending ED that would be suitable for attending an SDEC that would be open 8 till 8. When we looked at the admission data for this cohort of patients, they had a really high admission rate, which they knew, and they wanted to help us to get over that and to analyse it more. So 75% of those patients that attended ED were admitted, and that equated to 28 admissions per day. The average length of stay for those patients was 4 days, and the average length of stay for patients with social problems was 6 days. We then looked at the length of stay for those patients, and as you can see there, 20% of patients were admitted for less than 24 hours, and 24% of patients were admitted for less than 48 hours. So we knew that there was a cohort of patients there that didn't have a high acuity, and they were being admitted that perhaps could be turned around in an SDEC. We also looked at the care home cohort of patients that came in as well. And again, that's just interesting just to look at the most attendances occurred in hours, and most of them were admitted. Just move on to the next slide. We worked with the frailty team at QEH, and we came up with some new ways of working. Some of these were quick wins and some of them were longer term recommendations. And this is why now we're still working with them now, looking at what they're doing and measuring the impact of the changes that they've made. But the main recommendation that we made was early identification of suitability for SDEC patients, and to create an SDEC area within the hospital. To recommended that it would open 8 till 8, 7 days a week, and to look at the workforce to support that. And we've got the workforce modelling if anybody's interested in that for the unit. We know what the KPIs are. I won't go into those because I'm conscious of time, and we've already spoken about those earlier in the webinar. So we can just move on to the next slide. So after successful pilot, QEH opened their new frailty SDEC in 2024, and they repurposed an area of the hospital that was currently not in use. They have a referral criteria, and basically they stream the patients in ED every morning, but they've also got a frailty phone, and they've got access to GP, community practitioners, ambulance service, so that they can dial into the frailty phone and speak to somebody from the frailty team. So that's the referral criteria for the patients coming in. Just move on to the next slide. There is an inclusion criteria as well. I won't go into that in too much detail, but the detail is there, and we'll be sharing the slides. I just want to talk more about the impact. This was data that we got 6 weeks post-implementation. So within the first 6 weeks of the SDEC opening, 376 patients were seen. 82 of those patients were referred from ED, and 87% of those patients that were seen in frailty SDEC were discharged on the same day. The median length of stay for these patients was just under 12 hours, and the readmission rate was 17.3% at 30 days, which was down from about 23% when we first started working with them. If we just move on to the next slide. I just want to show you this slide, which I think is really powerful as well. And this is talking about the median length of stay for what the trust has seen. So you can see the blue line is a frailty SDEC, and the length of stay for that is approximately 12 hours. The AMU length of stay has reduced down from 4 days to 2 days. And the length of stay for the integrated care of the older person ward has reduced from 8.5 days to 6.5 days. And I think what's really important here is that we really see the change embedded after the first 6 weeks. So we're really seeing results between week 7 and 12. So that's a quick overview of what we did with QEH, and we do have more details if anybody is more interested in more. But I'd just like to hand over to Aaron now for his insight of the surgical SDEC.
Thanks very much, and thanks for inviting us to speak today. Hopefully, we'll be able to give a bit of an update on SDEC for surgery. We know from Nick's talks and for the presentations so far today that medical SDEC is a lot more mature, a lot more defined as a specialty, but surgery has been a little bit slow to the party, and hopefully we'll be able to talk about our experiences at Huddersfield. I'll see if I can control the slides. Has that slide moved on? Hopefully it has. So I'm going to try and talk a little bit about the evolution of SDEC at Huddersfield Royal, and then, much like our previous speakers, talk about various options of implementation and what some of the differences are between medical SDEC, if you like, and surgical SDEC. And then from our work from around and about, trying to highlight some common themes that seem to be analogous to lots of successful units around the country. So when we're talking about surgical SDEC, what do we mean? Well, really, we're talking about kind of those high volume, low complexity operations, those patients who come in a lot, who have relatively easy and quick treatment, and they're patients who can be turned around. I think one of the big differences to think about for surgical patients is that very often these patients, it's not just about the diagnosis and the beginning of a treatment that can then be continued in an ambulatory fashion. The actual delivery of treatment usually does need to happen in a hospital if it's an operation. And so trying to combine some of those principles with the principles of SDEC to try and improve our overall ambulatory capacity for these patients. We're not at the moment talking about our sickest patients, the laparotomies and so on. These are the well patients who traditionally form a big part of our bed base. So in terms of Huddersfield, in terms of why we started, it's basically because of the pressures that all of us see. Every single one of our units, every single one of our hospitals across our specialties has seen a marked and sustained reduction in surgical beds, and at the same time, a big increase in surgical referrals. But I bet that's going to be the same across the specialties, medicine, frailty, and so on. At the same time, there are really big pressures on general practitioners and on our EDs, and of course, increasingly, not just with the pandemic, but even prior to that, increasingly delayed presentations as our waiting times for elective outpatient clinics are increasing. So in terms of where we started, what I thought was really important to highlight was that we had some really key questions before we started on our journey. There were some things that we wanted to be really clear on. Of course, this is an evolutionary process. You try something, bits work, bits don't. But we had some clear aims in our mind before we started our same-day emergency care unit. We wanted to know what our aims were, to be really clear about what we wanted to achieve. We also wanted to know how were we going to demonstrate improvement if the hospital is going to invest in us. How are we able to demonstrate that we're doing things better? And then there were some practical things that we had to talk about. And actually, these are things that all hospitals have to work out now. Where are you going to put it and who's going to do the work? And we've touched on some of those themes on the previous talks as well. So one of the hardest things when you have a group of people and you say, what are our aims, is ultimately everyone will say something different. So we got a group of people together, some key stakeholders. We had some ED, we had some surgeons, we had some nurses, we had some managers and so on. And everyone's going to say something different. Of course, the ED colleague said, we would like you to reduce pressures on ED. Our managerial team was saying, we'd like to have fewer patients in beds. Our elective coordinators are saying, we'd like to release the surgeons to catch up with elective work. And I think this is one of the key differences between surgery or surgical specialties and other specialties. we have a big proportion of elective work that needs to be done. And actually, the big us at the moment are getting rid of the elective waiting lists. But our specialty is unusual in that most of the time, in most hospitals, the people who deliver the emergency work are also the people who deliver the elective work. But ultimately, we wanted to improve outcomes, improve survival, improve outcomes, and improve length of stay. So this is how we then thought how we're going to demonstrate an improvement. And it's all about data. So right at the beginning, be absolutely sure about who's coming to you, who's being referred, which patients are coming, and when in the day are they coming, how long are they waiting, what do they need, and what are their bottlenecks to their care. Because it's only by doing that that then you can start targeting your resource about what you want to improve with your SDEC unit or your ambulatory unit. It's actually impossible just to say we're going to do this without having a real specific focus on what to improve. It amazed me at the start of our project how much data is collected about each and every one of us and all of our patients. Our informatics department are brilliant. But what they need is a steer from us about what data they want to pull out and how we want to interpret that. Data in itself is not very helpful, but that contextual understanding, that clinical interpretation of the data is absolutely critical to then be able to improve your service. Naturally, of course, we then had to decide where to put our surgical SDEC unit. And this has been something that surgical SDEC units up and down the land have had to deal with, and I suspect lots of other specialties. So I thought I'd just talk a little bit about where ours is and talk about some common pitfalls. It's certainly my opinion and the opinion of several surgical teams that a shared SDEC space with multi-specialty areas don't really work for surgical patients. And I'll tell you why, hear me out. They're very, very different patients, and very, very commonly, surgeons or surgical juniors, surgical nurses are quite comfortable dealing with medical patients because it's very common that there are medical outliers. But it's been really striking how uncomfortable medical colleagues are dealing with surgical complications or surgical patients. Of course you can, but there are some things that are really clear that they simply wouldn't know. Can this drain come out? How do you manage a drain? Can you flush a drain, for example? The second thing is that there's very different volumes of patients. There's no doubt that medical admissions, medical numbers in SDEC are much, much greater than surgical volumes. And what inevitably happens if you have a shared space of people is they will go to where it's busiest. And so inevitably surgical patients can get neglected, and therefore they lose the benefits of ambulation and same-day care. And ultimately it's training as well. Surgical juniors are not there to do medical work. Medical juniors aren't there to do surgical work. And it becomes a very difficult thing to manage. You also lose some of the greater benefits of surgical ambulation, which I'll go on to in a moment. So in my opinion, it should be located where it suits the specialty rather than the hospital. But all too commonly, it's placed where it suits the hospital rather than the specialty. So ideally, I think the surgical SDEC should be co-located with your surgical juniors. Unless you're able to run two different on-calls, an SDEC team and an on-call team, which very few hospitals have the staffing or the budget to do, you've got to make sure that it's co-located with the people on that day delivering the acute surgical service. The reason is that people will always go to where the volume or the sickest patients are, which will be your SAU, and your SDEC will get neglected, unless they're all together or relatively co-located. Some of the themes I think we've talked about already. Obviously, it's important to have an area that can't be bedded. But actually for surgery, there's some other things which are really, really valuable. Apart from phlebotomy area and treatment areas, our SDEC in Huddersfield has evolved from being a primarily diagnostic area to now being a diagnostic and treatment area. So the vast majority of our abscesses, for example, are now drained on SDEC under local anaesthetic. But that's needed a change in our protocols to manage these. But equally, many of our patients who have general anaesthetics can now be recovered through SDEC. So think about the patient who arrives at 2 in the morning with a diagnosis of appendicitis. Historically, they're admitted, and then you wait for your lap appendix. Now, they're discharged after a dose of IV antibiotics. They come back at 7:30 in the morning to SDEC, have their lap appendix first thing on the acute list, and then they're recovered on SDEC and discharged. That's a GI operation delivered in an entirely ambulatory setting. And we're able to do the same with gallbladders, with abscesses, and so on. And occasionally going to come across the unknown. the new cancer and so on. So a quiet room, I think, is really important. You then got to think about who does the work, and there are loads of options. There's traditional rotas like ours at Huddersfield, a separate emergency general surgical team, hybrid versions, and subspecialty on-call. It really doesn't matter which one of these things that you do, in my opinion. I think it's the principles that are the key rather than the method. But equally, you've got to look at the finances. We simply couldn't afford to employ 10 new emergency general surgeons, for example, to deliver our acute service here at Huddersfield. And then finally, I think it's really important to have a really clear sense of what you want to do, a clarity of purpose, a very, very clear SOP, so that everyone in the hospital who's going to use your surgical SDEC knows what we do, what we don't do, and what to expect. Your GPs know. We send out leaflets to the GPs that they give to their patients when they refer to SDEC. So we know the patient should come fasted. They know to expect to wait for a few hours. A map to tell them where SDEC is. Simple information. We don't have exclusion criteria. The principle is SDEC until proven otherwise. And we try and minimize the opportunity of admission as much as possible. But equally, it's important for the specialty to push back against unreasonable demand. Naturally, success breeds demand. So the more you do, the more you'll be asked to do. And we've been very careful to say, I'm sorry, we can't do that. If there's a patient who's been referred from ED, who has been accepted for admission, SDEC is not an appropriate place for that patient to come to wait for a bed. It is an ambulatory same-day place. And so it's pushing you back about some of those things as well. And in terms of our data, this is where we are. Fewer admissions, low mortality, much better outcomes. Over 80% of our admissions now are managed in an entirely ambulatory fashion. And we've been able to lead to a permanent reduction of surgical inpatient beds by a ward. We've dropped our inpatient base by an entire ward. And that's not impacted our elective times that we're waiting either. Over 80% of our ED referrals now never see an ED doctor. We screen them straight from triage without seeing a doctor at all. And we've had a trebling of some of our operations, and acute cholecystectomy is just the best example. But it's so important we think about the doctors of tomorrow. And it's actually a great opportunity for training. We've been a doubling of cases for our trainees as well. We've led to sustainable working patterns. And I think some of these things are really features amongst high functioning units. There's a respect amongst consultants. There's no second class consultant. You do emergencies, we don't. You're a subspecialty consultant, we're not. We're all treated the same because at the end of the day, we're all emergency surgeons. Those departments that have diabetologists that don't do acute, cardiologists that don't do acute, in my opinion, that leads to a breakdown in communication at times. We all see ourselves as the same, and we're pulling in the same directions. And that healthy relationship between clinicians and managers is crucial. Our systems are designed with the clinicians rather than imposed upon us. And we've been very lucky to be very well led by our managerial team. And that sharing of data and sharing of job plans, each of us knows what we get from each other's job plan is really, really crucial. So no one minds doing the acute work. And it's dealt with in the results. Although we've talked about ambulatory care, in my opinion, those that do the abscesses well do everything well. And these are some of the results from the National Emergency Laparotomy Audit. And you can see we're very proud to be one of 4 hospitals named as having statistically low mortality in the UK. And that stems from the fact that you can concentrate on your sickest patients if your bed base isn't being taken up with volume. So in summary, I often think that when you're setting up your service, the best is the enemy of the good. Someone a lot cleverer than me said that a long time ago. But I think actually, whatever you do, do something. Sometimes it feels overwhelming to start a journey, but pick one thing and start it. Some of the most successful surgical SDEC units started with an abscess pathway. Start that and evolve it, and then go from there. I'm very happy to take questions at the end, and thank you for the time to be able to present today. Really appreciate it.
Thank you very much, Aaron. Thanks, everyone. And thank you, everyone, for attending. I apologize that we have run out of time. I hope that the webinar has been of interest to all of you that have taken the time today. We are very happy to stay over and take some questions as well. But equally, for the ones that have to drop off, I just wanted to mention that we'll be running 2 drop-in sessions for those that would like to ask more questions, would like to learn more about SDEC development, and we'll be sending all that information in an email shortly, together with the recording of today's webinar and all the slides as well. I would like to thank everyone that listened to us, but especially to Nick, Tara, and Aaron for joining us today. I think it's been very insightful, and everyone has appreciated your time and sharing all your insights. And good luck to everyone, and thank you for coming today as well, especially if you are embarking in your own SDEC development journey yourself. We will now stay behind and answer any questions that you may have, but equally we'll be able to answer questions by email directly or in the drop-in sessions. Thank you very much, everyone.